Hello, this is Dr. Emma Gatman. I'm professor and vice chair of the Department of Dermatology at the Icahn School of Medicine at Mount Sinai Medical Center in New York. I would like to welcome you to this educational activity that is focused on updates in atopic dermatitis treatments that were presented at the 25th European Academy of Dermatology and Venereology Congress in Vienna, Austria.
The following audio is from a two-part presentation with Dr. Emma Gutman-Yaski. This audio is part of a certified educational activity titled New Developments in the Treatment of Atopic Dermatitis, Clinical Highlights from Vienna. To access the entire activity and complete the post-test, please go online to www.peerreviewpress.com/RAV. A printable monograph, slides, practice aids, and other features are also available.
Atopic dermatitis is a chronic disease that significantly affects the quality of life of our patients. In particular, patients with moderate to severe disease report a significant burden of itch, pain, sleep disturbances, anxiety, depression, and impact on health-related quality of life. Additionally, data are emerging that atopic dermatitis has systemic abnormalities, perhaps even more so than psoriasis, another inflammatory skin disease associated with systemic abnormalities. Therefore, we must be able to effectively treat this disease. Developments in the treatment of atopic dermatitis are continuously being made, and many of these advances were recently presented at the 25th European Academy of Dermatology and Venereology, or EADV, Congress in Vienna. Let us begin with a discussion of updates on the current treatments that were presented at the EADV. Patient education is an important component of atopic dermatitis management. A randomized multi-center study in Germany on the effects of structured patient education on adults with atopic dermatitis was presented. The education was a comprehensive 12-hour training session with a multi-professional team consisting of a dermatologist, a psychologist, and a dietitian. Significant improvements in the signs of atopic dermatitis were observed with the training group compared with the control group. Therefore, a multidisciplinary approach could be an effective tool to improve outcomes of adult patients with atopic dermatitis. A presentation on difficult-to-treat atopic dermatitis included a few recently published studies on the use of topical corticosteroids. For example, one study showed that after topical corticosteroid administration, with or without bleach baths, bacterial compositions on lesional skin normalized, resembling that of non-lesional skin. Another study demonstrated that adding topical steroids to pre-soaked skin was not more effective compared with application to dry skin alone. Patients frequently seek complementary and alternative medicines for atopic dermatitis. To gain insight on their efficacy and safety, a systematic review of use of topical herbal medicines in atopic dermatitis was conducted and presented at this EADV. Many of the studies included in the analysis had methodological flaws, and those showing evidence of efficacy were single trials with only few patients. A meta-analysis was not conducted due to heterogeneity seen in the studies. The authors concluded that there was insufficient evidence of efficacy for the use of herbal extracts in atopic dermatitis, and more studies are needed to clarify the role of these therapies. Although not approved in the United States for atopic dermatitis, azathioprine is one of the treatment options in the management of severe atopic dermatitis that is not well controlled with topical therapies. However, metabolites of azathioprine may lead to toxicity if a certain level is reached. A prospective study investigating the relationship between azathioprine dose and the metabolite levels and their correlation with therapeutic response was presented. The findings of the study implied that measurement of azathioprine metabolites in patients with atopic dermatitis is feasible and safe. Moreover, the addition of allopurinol 100 mg per day to the reduced dose of azathioprine can be useful in patients with metabolite imbalance. However, I must remind you, azathioprine is not approved for use in the United States for atopic dermatitis, although we use it off-label. There were also a few studies which explored factors that may predict response to treatment. For example, one study examined associations between filaggrin or filaggrin null mutations and atopic dermatitis in a Finnish population. The combined filaggrin null phenotype was associated with early onset atopic dermatitis, palmar hyperlinearity, and asthma in the context of atopic dermatitis. However, the filaggrin status did not have an effect on disease severity or on treatment responses. Furthermore, a recently published study that I was involved in found that filaggrin expression was not downregulated in early onset atopic dermatitis in early childhood, challenging the notion of filaggrin as central for disease elicitation and as an instigator of the entire atopic march. Another study presented examined the prediction of response to mycophenolic acid. At least half of the patients do not respond to this treatment, and non-responders end up taking the drug for more than 3 months with no benefit and, of course, a risk for adverse events. This retrospective study assessed whether UGT1A9 polymorphisms correlated with non-response to treatment with mycophenolic acid in patients with atopic dermatitis. Significantly more polymorphisms were observed in the non-responder group. The study found that 18.8% of the non-response to mycophenolic acid was explained by the presence of these polymorphisms. A larger prospective study is planned. These findings highlight the potential for personalized medicine in atopic dermatitis, where treatments are prescribed based on patient-specific factors, and ineffective treatments for individual patients may be avoided. An additional study presented at the ADV explored factors that predict remission of infant atopic dermatitis until adolescence. The analysis included more than 1,000 patients. The most important predictors were eczema location, the severity of eczema, paternal atopic dermatitis, and few other parental factors. So far, we have reviewed updates in currently available atopic dermatitis treatments that were presented at the ADV. Stay tuned now for the next segment, where I will discuss new data on emerging therapeutics for atopic dermatitis. Many patients with atopic dermatitis are not adequately controlled with the currently available treatments. Of note, whereas in Europe, oral cyclosporin A is approved for patients with moderate to severe atopic dermatitis, in the United States, only oral prednisone is approved for their treatment. And most dermatologists, including me, would prefer not to use it due to multiple side effects and rebound, and in fact, I did not prescribe it. In a study for which a poster was presented in Vienna, 42% of the patients with moderate to severe atopic dermatitis reported that their current treatments were ineffective. There have not been new therapies developed for the treatment of atopic dermatitis in more than 15 years. However, there are many agents now in development as presented at this meeting. Let's now examine new treatments presented at the ADV. Dupilumab is a human monoclonal antibody that targets the alpha subunit of the IL-4 receptor, thereby inhibiting the actions of the Th2 cytokines, IL-4 and IL-13. This agent is currently under FDA review for the treatment of adult patients with inadequately controlled moderate to severe atopic dermatitis. Late-breaking data from the Phase 3 SOLO-1 and SOLO-2 trials were presented at this ADV. These were two identical studies in which moderate to severe patients inadequately controlled with topical corticosteroids were randomized to receive placebo, 300 mg dupilumab every 2 weeks, or 300 mg dupilumab weekly for 16 weeks. Both dupilumab doses resulted in a significantly greater proportion of patients achieving an IGA of 0 or 1, that means clear or almost clear, and at least a 2-point reduction from baseline compared with placebo. More patients in both dupilumab arms also achieved at least 75% reduction in their eczema area and severity index, or the EASI score, as compared with placebo. The improvement in EASI score from baseline with both dupilumab arms was significantly greater than that of placebo in both studies. Significant improvements in pruritus or itch were also observed as early as week 2, which is important as itch is a hallmark of atopic dermatitis and a very significant symptom for these patients. In both studies, both doses of dupilumab were also associated with significant improvements in Dermatology Life Quality Index and Patient-Oriented Eczema Measures, or POEM, as well as significant improvements in anxiety and depression. So not only does dupilumab improve symptoms, but it also restores the quality of life for patients with atopic dermatitis. Notably, patients in the study had a median affected body surface area of 50%, representing a population with severe atopic dermatitis or severe eczema for which there is a significant unmet need for novel treatments. An example of a patient who achieved the primary endpoint with dupilumab weekly was presented. This was a patient with a duration of atopic dermatitis of 48 years. At week 16, the patient's IGA score decreased from 4 to 1. The affected body surface area went from about 86.5% to 2.5%, and the EASI score went from 51.5 to only 3.1. And the pruritus NRS score decreased from 7 to 1.6. In general, dupilumab was well tolerated. Most adverse events were mild or moderate. Injection site reactions and conjunctivitis were more frequent with dupilumab. There were no observed increases in infection with dupilumab. Therefore, dupilumab represents a promising option for adult patients with moderate to severe atopic dermatitis. We are very excited that there is a new treatment that provides better safety and efficacy than the existing treatment options, and can be used long-term, as we currently do not have effective treatments that can also be used long-term for our patients with severe atopic dermatitis. Another atopic dermatitis treatment that is under FDA review is crisaborole, a topical phosphodiesterase inhibitor. This agent is being investigated for the treatment of mild to moderate atopic dermatitis in both children and adults. Recently published phase 3 studies showed improvement with crisaborole versus placebo in all measures of efficacy, including overall disease severity, pruritus, and other signs of atopic dermatitis. Results from these studies demonstrating the effects of crisaborole on quality of life were presented in Vienna. Crisaborole was associated with significant improvements in quality of life in both age groups, 2 to 15 years old and also 16 and above, for patients as well as their families. The long-term safety of crisaborole was investigated in patients 2 years of age and older with mild to moderate atopic dermatitis who were included in an open-label extension of the phase 3 studies. Safety data were pulled from the 2 28-day phase 3 studies, as well as the open-label 48-week safety study. Pooled treatment-emergent adverse events occurred at a low frequency across all age groups and over time. The most frequently reported treatment-emergent adverse events were atopic dermatitis 3.1%, application site pain 2.3%, and application site infection 1.2%. The majority of treatment-emergent adverse events were considered mild or moderate and not related to treatment. There were no reports of long-term cutaneous adverse reactions. In the extension study, none of the reported serious adverse events were considered treatment-related. Less than 2% of patients discontinued the extension study due to treatment-emergent adverse events. Therefore, the safety profile of crisaborole topical ointment 2% was favorable for long-term treatment of patients aged 2 years and older with mild to moderate atopic dermatitis. We are excited to have new and safe topical treatments for our patients with atopic dermatitis. Another late-breaking presentation of phase 2 data was for treatment of moderate to severe atopic dermatitis patients with Lebryk Kazuma. Lebryk Kazuma is a humanized monoclonal antibody that binds the IL-13, a key Th2 cytokine with an important role in the pathogenesis of atopic dermatitis. The patients included in the study were 18 to 75 years old with moderate to severe atopic dermatitis for at least a year with an inadequate response to topical corticosteroids. The patients were randomized to receive either placebo or lebrikizumab 125 mg single dose 250 mg single dose, or 125 mg every 4 weeks. All patients also received topical corticosteroids twice daily. Dosing every 4 weeks resulted in significantly higher proportions of patients achieving 50% and 75% improvements in the EASI scores, as well as 50% improvement in the SCORAD scores, another scoring index for atopic dermatitis, with trends for improvement in pruritus and the proportions of patients achieving clear or almost clear skin. Significant improvements were also seen in the placebo group, and it would be good to have a monotherapy study in the future to really evaluate for drug effect without the effect of topical steroids. Adverse events were similar between treatment groups, and most were mild or moderate in severity. DS-107 is another emerging treatment being studied in atopic dermatitis. This drug contains the active pharmaceutical ingredient DGLA, a 20-carbon polyunsaturated bioactive lipid. A phase 2A proof-of-concept study was presented in patients with moderate to severe atopic dermatitis. Analysis of the primary endpoint, which was at least a 2-point decrease in the IGA and a score of 0 to 1, showed a trend in favor of DS-107 over placebo at 8 weeks. There was an increase in the number of responders when only patients who completed 8 weeks of treatment, the observed population, were included in the analysis. A post-hoc analysis showed statistically significant decreases in IGA score with DS-107 compared with placebo when patients were stratified by site and severity of the atopic dermatitis at baseline. Statistically significant improvements in pruritus and POEM scores were also observed after 4 weeks. DS-107 capsules were well tolerated up to 2,000 mg on single dose. The majority of adverse events were GI-related, transient, and resolved without any intervention. Nemolizumab is a monoclonal antibody that targets IL-31, the itch cytokine, for which phase 2 data were presented at the ADV. There was a rapid dose-response reduction of the pruritus. Sleep and quality of life were also improved. Improvements in dermatitis as determined by EASI and achievement of an IGA of 0 to 1 were also observed. Frequent adverse events occurring in at least 5% of patients included worsening of atopic dermatitis, nasopharyngitis, upper respiratory tract infections, and peripheral edema. No increases in infection or deaths were observed with nemolizumab. A recently published phase 2 study investigating a treatment used for psoriasis targeting the P40 subunit of both IL-12 and 23 cytokines, namely ustekinumab, in adult patients with atopic dermatitis was also presented. The ustekinumab group achieved higher SCORAD 50 responses at week 12, 16 weeks, which was the primary endpoint, and 20 weeks compared to placebo. But due to the small sample size, the difference between groups was not significant. This can also be due to the use of topical steroids and the use of the psoriasis dosing regimen, which may not be sufficient for patients with atopic dermatitis that may have higher systemic immune activation. The next study I would like to talk about is a phase 2A trial investigating the use of topical JAK inhibitor tofacitinib in atopic dermatitis. At week 4, 73% of patients receiving tofacitinib achieved a physician global assessment or PGA score of 0 to 1, compared with only 22% of those receiving the control vehicle. A significant reduction in each was also observed with tofacitinib. The most frequent treatment-emergent adverse event was respiratory tract infections, but in general, adverse events with tofacitinib were similar to the vehicle. In this meeting, we obtained this time the final proof we needed for the lack of a pathogenic role of IgE in atopic dermatitis, since a high-affinity anti-IgE molecule achieved no clinical benefit in patients with moderate to severe atopic dermatitis. So to conclude, atopic dermatitis has a significant impact on patients and their lives. New insights are emerging on current treatments, including factors that can predict response to treatment. Studies have challenged the previously conceived notions of filaggrin and IgE playing important roles in the development of atopic dermatitis. 2 new treatments, dupilumab and crisaborole, are under FDA review and may be available soon, and a variety of other treatments are in phase 2 of development. Therefore, the treatment of atopic dermatitis is likely to evolve in the near future, and it is a very exciting time in this field for patients and their physicians. It will be important to have monotherapy studies conducted, as the background use of topical corticosteroids may affect and interfere with the interpretation of the clinical effects of these agents, as we see in this meeting. Well, that ends our discussion for today. I hope you found it informative and useful. Once again, I encourage you to download the slides and practice aids for this activity. Don't forget to access the post-test and evaluation form by clicking the red Get Certificate button. Thank you very much for participating in this educational activity focused on updates in atopic dermatitis presented at the 25th EADV Congress.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/RAV. This educational activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals.